dilation, lesion preparation, and wiring. Then main vessel stenting with jail wire and side branch. Then that means post dilatation optimization of proximal part of the stent. And then 4, if you do not have any compromise of side branch, no chest pain, no ECG change, and TV free flow on the side branch, I think you do not do anything, no need for bailout. If, and this is the 4th, the last step, that you should check with IRIS again and see that everything is in place. The mechanism of side branch occlusion during bifurcation lesion interventions are different. Might be carina shifting, might be plaque shifting, might be dissection, and might be also valgus. So accordingly to what happened, you should understand what is going on in order to decide how to bail out your side branch. And if you look, we have some predictors that you can expect the occlusion of side branch and are listed in this in this table, as well as we have also criteria from IRIS that can predict the occlusion or shifting of plaque or carina during stenting the vessel. So all these elements should be taken in consideration when you are going also for simple bifurcation. When you have some compromise on the side branch, so this can occur during pre-dilatation, can occur during stenting, main vessel, that means intravenous stenting, or so to move to the two-steps approach, tap or block in order to bail out. Not always is required, you might also bail out with and if you have you expecting some compromise on the side branch, I think we have also active side branch protection techniques, starting from jail wire, jail balloon, jail protector modification, and finally the result can be, if it is not possible to correct with only balloon, stenting side branch. Now I'm going to my case. This is a very simple case. This is a male of 69 years old with hypercholesterolemia, hypertension, and he was cigarette smoker. Extracardiac diseases was mild renal failure and obstructive pulmonary disease. No symptoms until 2018. November that year, we have effort angina, class 2, and medical therapy, no other episodes of angina. In January last year, we appearance of effort angina, 3rd class of functional class. Exercise test was stopped at low, 3rd step for angina and ST depression in anterior leads. He was planned for coronary angiography, and he came for in February to Catholic. This was the angio. You can see that the only lesion is on distal left main. It is not very clear on angio whether it is 111, 112, or else, and the severity also is not quantified by angio as well. So it has been mentioned before how to define simple and complex bifurcation lesion, and I think that the definition study finally gave us more criteria in order to be based on in classifying the bifurcation, whether it is simple or complex, and accordingly to go for simple or complex bifurcation. And this is not coming only by angio, but I think we should go also for IRIS in order to be sure that you are choosing the right criteria. Like in this case, you see on angio, it seems intermediate lesion on distal left main, and maybe significant lesion on ostial LAD, and maybe also ostial SERP is involved, but you can, because of this difficult anatomy, you cannot define what you are having in by only angio. So if we look on IBUS, then you can see that on angio it seems like 111, but in IBUS it was 110 lesion because the ostial circumflex was free of disease. So the intention to treat in this patient, again, classical provisional stenting, wiring of lesion, pre-dilatation, lesion preparation, single stent from left main to LAD, and port, rewiring circumflex, balloon angioplasty through the struts, and final kissing balloon if needed. Again, here the steps. And this is what happened after stenting the vessel. You see now we have tight lesion on circumflex, but we do not know whether it is dissection, whether it is shifting of plaque, whether it is navuspan, or so on. So the first thing for me is to give some nitro and wait for some minutes if patient is not complaining about angina, and see what happens. And they're still having, after nitro, you can see that still having some disease on, some compromise on circumflex. And we went with FFR, and FFR in this vessel was 0.80, that means borderline, but should be considered like significant in this case. So we decided to go for the new correction, the new angioplasty, and in this case, it is recommended to go with the side of the knee, to cross the lesion, to open the struts, and to see what happens. That by physiology, you go again and see what you have produced by your inflation. And that's
you have 1 minute left.
Yes, and this was the result after balloon inflation. The ostium of circumflex seemed very good and confirmed by FFR, and this was the final result because we stopped here and we did IBUS, and IBUS was showing that the result was excellent. So bailout is not only stenting, bailout can be also done by balloon, as you can see in this case, very simple. Thank you very much for that.
Thank you. So we're running very short. Our next session is debate. One is in favor of intravascular imaging in bifurcation PCI. Dr. Iman Salan will tell in favor of imaging, and Dr. Talush Bhatia will be against the intravascular imaging in all bifurcation PCI. I would like to request Dr. Talush Bhatia first for his speech. And thereafter, Professor Iman Salan.
I have seen that a lot of participants are interested to know about the imaging studies before the use of stents in limping and bifurcation as well. I think this debate should be the end after the great debate of use of image. I think this should be the end of this today's session.
You have got 10 minutes time.
So, my talk is slightly difficult because personally I would favor imaging in bifurcation, but do we add that in all our patients? The use of intravascular imaging in 2014 is 6%, but the recent current scenario, especially in left-hand bifurcation PCI, it has stepped up to 50%. But the utopia does not exist. We are not able to use imaging in 100% of patients as advocated by all the panelists and chairpersons earlier. So we do have limitations of cost, availability, time, physician, inertia, training. So the debate is not about that we know it all and we can do it without imaging. We do not have either size or OCD lines. But whether we will be able to develop a bifurcation protocol to envision the various bifurcations with or without imaging, that is the question. So the first and foremost strategy that we usually use in our approach is to use an adequate stepwise provisional strategy. This is a Medina 110 left wing and LED critical disease in a case of anterior wall MI. And we did a provisional strategy with the optimal pot and thereafter used imaging to document our result. I would just exemplify in this case what the imaging could offer and what it could not. So the imaging was done post-stenting and we had an adequate result in left vein and LED and we could notice a distal stent edge dissection that could or could not have been managed according to the extent of the dissection. And at the bifurcation view, we could see the oblique struts in the left LCX ostia. And just to be more precise, what the ostial lesion at ostial LCX would be, we took a OCT run pull back from L6 ostia back to left vein and the MSA was 2.5 millimeters square. But with the FFR that was negative. So the imaging actually was favoring the intervention and according to the literature that we have now, even if we have a MLA of less than 3.7 millimeters square, it does not predict a FFR of less than 0.80 and the positive predictive value is only 15%. And this patient was followed up at 6 months and the FFR at that time was 0.96 for L6. So this is a beautiful case of visual functional mismatch, not just on the basis of angiographic stenosis but also MLA FFR mismatch. And it is under these situations that we understand that in left vein bifurcation, the functional significance comes over left vein bifurcation over imaging in such a context. So the first strategy that we discussed was a stepwise provisional strategy in which the imaging was offset by the use of functional significance. But not all bifurcations are equal. We need to individualize our approach and we can always switch to the two-stent strategy after the provisional strategy with a TAP or QLOC. So these cases were done without imaging. This is a provisional strategy where we had to deal with two bifurcations, a LED diagonal as well as a left vein to left vein bifurcation including the ramus as well as LED posterior. And we did it without the imaging. And this is just to exemplify that we can predict what is being done with just angiography and stent boost. And it is more important to handle the ACS or the current situation in the main branch rather than to just spend our time over imaging. We can always go back to imaging as and when needed. I would not say that OCD would not have its advantage. Its clinical value, however, remains to be established. It definitely depicts the ostia beautifully, but the time, the contrast, and sometimes it may mislead or give us over interventional inferences. Obviously, with the advent of 3D reconstruction of OCT with the mini-vessel pullback, that is super awesome. But I would like to question how many times would we assess the ostia before the procedure, during the procedure, after the procedure, especially if there is a side branch critical stenosis, whether or not we will be able to image its pullback nicely. And whatever data that we have as of now are mechanistic data. We do not have real world picture as well as randomized controlled trials, and whatever trial that we have are also in small numbers, although the data of OCT is just increasing. In contrast, I would prefer IVUS because we can always use it over and over again, use it multiple times, even if we have some kind of decision in subsequent steps, especially especially with DK Crush, that has approximately 10 steps. How many times would we be using pullback with a OCT catheter? And even with the prospective studies, like in opinion study, there were only 38% of patients with bifurcation with no specific protocol for handling bifurcation, and the Illumin 3 had actually excluded two-stage strategy of bifurcation. So until and unless the imaging studies have more power, till then we do have the conventional use of IVUS that slightly is better, especially with left brain stenosis. So this is a 68-year-old male. I'll just rush through it because of the lack of time, but I will just try to exemplify it's not just imaging that helps in our decision.